Welcome, everyone. If you don't know me, I am Dr. Ellen Hartenbach. I'm the chair of the Obstetrics and Gynecology Department, and I am just delighted to be able to speak a little bit this morning about the symposium. I'm glad that everybody out in the ether can hear us as well. I just want to give a few remarks about the symposium before we start the symposium. We have got a great program for you this morning, but the event is special. It's celebrating a special anniversary, the 20th anniversary. This event was founded by Dr. Gloria Sarto and Dr. Gloria Johnson-Powell in 2005, long before people were talking about health equity and health disparities. The two Glorias on campus we're really working hard to make issues come to the fore. So this is the 20th symposium. It's an exciting accomplishment, and I'm just going to tell you a little bit about the symposium over the years. And I'm going to check my, and I'm going to use this. And Autumn's going to advance my slide. No, I should be able to do this, Autumn. Give you a minute to wake up.
Now try.
This one?
Do this one.
Oh, there we go. Okay. So the amount and variety of research at this event in the 20 years is really impressive. In just the last decade, we have numbers for the last decade, people shared their work through 55 presentations and 283 posters. The themes are interesting, and you can see in this word cloud, the most commonly represented themes and topics from the last decade. While the focus of the event has always been on health equity, we can see that there's health disparities across all kinds of corners of reproductive health care, from pregnancy to cancer to adolescent health and beyond. Peers from schools and departments across our campus have joined us to present their work, helping us build a truly interdisciplinary connection and foster collaborations that have really enriched our department's research and clinical care. And at this event, we've invited a lot of distinguished keynote presenters, including today. We've had people from around the country to share their thoughts about how health disparities show up in many aspects of reproductive health care. We've hosted leaders from the National Institute of Health, the National Institute of Child Health and Human Development, past presidents of the American College of Obstetrics and Gynecology, and more. And it's really been a privilege to meet them, to learn from them, and to hear from the leaders from across the country. We really owe the success of this event to Dr. Gloria Sarto. Many of you in the room know Dr. Gloria Sarto or knew her. She's a longtime leader in obstetrics and gynecology in Wisconsin. She also has been a leader across the nation. She completed medical school and OB/GYN residency and got her PhD in medical genetics here at UW in the 60s and 70s. She was a member of the faculty. She did her early part of her faculty years for the first 10 years here in Wisconsin. Then she went on to be a faculty member at Northwestern in Chicago, and ultimately the chair of obstetrics and gynecology at the University of New Mexico. And normally that would be enough for people because that spanned 40 years. And then as a native of Racine, Wisconsin, she came back and served as a senior faculty member and emeritus faculty member in our department for over 20 years. So she came back around the turn of the century. And it's just amazing what she accomplished in her latter part of her career here. She was a fierce champion for women's health and health equity. She worked with national leaders in the 90s to establish the NIH Office of Research on Women's Health. She brought the Health Disparities Research Scholars Program, which is a postdoc scholars program with funding from the NICHD. Yeah, we got maybe some scholars in the audience. Yeah, amazing, amazing. And it's been continuously funded since that time. She also was the first female president of the American Gynecologic and Obstetrics Society. And that was after the society had been in existence for over 100 years. So she was really a force. That's one of the national honor societies. I don't know if AGOS is an honor society, but it sort of is. As a national voice for women's health, she had tremendous influence on public policy, educational curricula, national research initiatives. Her impact on reproductive health training and research in Wisconsin and across the country is just immeasurable. In recent years, she turned her passion towards establishing a health education and outreach nonprofit to improve health literacy in Dane County. And to the last, she was continuing to raise funds for this effort that she just cared so much about. Dr. Sarto passed away in June of this year, and in her honor, and to promote her enduring legacy, this year we have renamed this event in her honor, and it is now and hereforward to be called the Gloria Sarto Reproductive Health Equity Symposium. Yay! And I'm sure this meeting will remain a crucial connection point for healthcare professionals, population health experts, community advocates, and those who are dedicated to advancing health equity, just as she had envisioned in 2005. And her memory will live on. For those of you who knew her, you know that. And for those of you who didn't, I hope that this little bit of information will help you understand the important impact of Gloria in the department. So finally, I'd like to thank the planning committee. I'm gonna just read off their names. I'm gonna make you all stand up. So Cheryl Casey Grant, Anastasia Dougherty, Carol Lloyd Gaines, Autumn Hayes, Carol Holland, Claire Lerma, Manish Patenkar, Katie Sempenny, Serena Schrager, Lisa Scott, and Laura Swan. So if you're here, stand up. We need a round of applause for everybody. Just incredible. Just incredible. Every year we get a group of people together once we finish the symposium, and every year is better than the last. I also want to thank a few extra people, Jamie Reitz, who coordinates all the travel for our grand rounds and keynote speakers and does a fantastic job. So thanks to Jamie. And finally, to the communications team. Let's clap for Jamie. Clap for Jamie. And finally, for the communications team, Jackie Askins and Rob Garza. You know everything they do in the department, so I think they need a round of applause as well. Okay, so down to a little bit of business. There's a QR code at the end of your aisles. I guess they're aisles. I don't know. And that's where the symposium schedule is. So QR code's there for you. For those of you in the chat, there's a QR code in the chat, right, Autumn? Yeah. QR code in the chat. Oh, and you know, Autumn is on the planning committee, but no events happen in this department without Autumn Hayes. So another round of applause. And she takes her role in this one particularly seriously. So thanks, Autumn. The other thing I want to say is a special thanks to Dr. Katie Sempenny. She has been the chair of the planning committee for the past 3 years, done a fantastic job getting the keynote, corralling everyone. And so really our debt of gratitude to you, Katie. Thank you so much. And if you're not finished clapping, I'm also happy to announce that Dr. Jenny Higgins is going to take over as chair of the planning committee for next year, and we're indebted to her. She is the director of our Division of Population and Reproductive Health and an amazing scholar in the field of reproductive equity. So thanks, Jenny, wherever you are. Really appreciate you taking it over. Okay, and now on with the show. We're going to start with brief and brilliant talks. Which is, I think, a fabulous new addition because you get a little snippet of what's going on for people, and it really keeps people interested. Anastasia Dougherty, who's one of our certified nurse midwives in our Division of Academic Specialists and on the planning committee, she is going to come up and she's going to introduce the brief and brilliant speakers. So thank you, Anastasia. Your turn.
Good morning. Thanks everyone for coming. I do have the pleasure to introduce our selected speakers from multiple applicants. We got many applicants to speak today, and these 5 were selected this year for the brief and brilliant talks. I wanted to remind what Dr. Hartenbaugh said. There is this QR code. You can also use that to access more information about the speaker's content and connect with them individually, because the the format of Brief and Brilliance does not allow for Q&A. So don't jot down questions thinking you're going to be able to ask them, but you may ask them by connecting with them afterwards. So our first speaker is Jenny Higgins. She is the director of both the UW Core and the Division of Reproductive and Population Health, and she's a professor of the Health, Rights, and Justice Department. Then Dana Johnson is the Health Disparities Postdoc Fellow in the Population Health Sciences Department. Lee Senderowitz is the Assistant Professor in the Department of Gender and Women's Studies and the Department of OB-GYN, and the Research Director for Gender and Reproductive Health. Alex Christensen is a PhD candidate in the Department of Medical Physics. Unfortunately, I think our fifth speaker is unable to attend today, but you can probably still connect to her content that she was going to speak about today via the QR code. So please enjoy, and let's give a round of applause to everyone as Jenny comes up.
Morning, everybody. My tendency is to want to walk, but I think I need to stay by the microphone for the Zoom folks. So my name is Jenny Higgins, but I'm really presenting today on behalf of Jane Seymour, CORE's research scientist and an epidemiologist who is the powerhouse behind this model and whose tailcoat I'm just riding. So when we think of abortion access, a term we hear a lot in our field and in the popular media, what do we mean? Well, we mean a lot of different things. Access could mean distance to care. It could mean whether somebody can afford care. It could mean when someone actually reports to a clinic for care, do they receive high quality patient-centered care and/or the abortion modality that they wish to receive, among other things. So it can mean all of these things, and yet the research literature as well as the programmatic work around abortion access lack a clear definition or operationalization of what we mean by abortion access. And that's where Jane's model has come in. So Jane has developed this model based on a very classic model out of health services research, Pachansky and Thomas's Dimensions of Access Framework from 1981. And we have adapted that model and added a couple of abortion-specific pieces to develop what we think is a clearer, stronger concept of abortion access. And I want to highlight a few domains just for examples to let you know a little bit about what this model entails. So let's take proximity, which is probably one of the easiest ones. This is just distance to care, right? So this is the relationship between where folks live and where services are located. And a couple examples of Wisconsin and how we have diminished access here, particularly for folks living on low incomes. We know that prior to Dobbs, in the years following 2010, 40% of clinics closed in the state, and core research has shown that those closures led to decreases in abortion rates and increases in birth rates, suggesting that this domain of access has been diminished. Let's take availability. Even if you live down the street from a clinic, if it's not open when you can get there, or if the abortion modality that you wish is not available or hard to get, then you are limited in your access. So this is the relationship between the types of care and patient demand. And let's take Wisconsin as an example. We know that outside from life-saving care, between June 2022 and September 2023, there was no availability in our state. Even after abortion services resumed, we know that medication abortion restrictions here are so intense for both patients and providers that that domain of access is limited for a lot of folks. One final example that I'll highlight is awareness. Even if all these other pieces are in place, if someone doesn't know that services are available, then they don't have access. And we have found in our interviews with folks who are pregnant in Wisconsin after Dobbs, there's a lot of confusion about what's legal and what's not. And folks concerned, for example, that even leaving state lines to get care would put them at risk for being criminalized. This is an all or nothing model. So if there's one domain of access that doesn't exist for someone, then they don't have abortion access. So we need to take a really holistic approach. I think we are arguing that this unified concept can help us better identify barriers to wanted abortions outside from just clinic locations or number of physicians, and also better understand and address what constrains and expands services. And our chapter with this model is forthcoming in a book edited by Katrina Kimport out of UCSF. Thanks all for your attention. I appreciate it.
Good morning, everyone. My name is Dana Johnson, and I am a health disparities research postdoc here at UW-Madison, and I'm really pleased to talk about some of our work on adolescence and demand for medication abortion from an online telemedicine service, both before and after the Dobbs decision. So as many people here know, adolescents face incredible barriers to abortion care, particularly minors, those under 18. In 36 states, minors must involve a parent or guardian in their decision to have an abortion, and these are by way of parental consent laws, parental notification laws, and laws that ask for both consent and notification from a parent. So that's already on top of, right, this really restrictive policy landscape for accessing abortion care. And there's really only a handful of states in the US where a teenager under 18 can have an abortion without involving their parent. And we'll notice, of course, that Wisconsin is not one of those places. So with all of these abortion restrictions, how are people under 18 accessing abortion in the US? Of course, some people aren't. They're continuing to be pregnant, or they're continuing to parent. Others might be involved in the judicial bypass process, where they appear before a judge and get a court order so they don't have to involve a parent. Others might be traveling to other states where they don't have to involve a parent in their abortion. And others, of course, are probably looking online. They're seeking out ways to either self-manage their abortion, they're looking for telehealth or online telemedicine services. So we wanted to understand a little bit more about that specific pathway, adolescent demand for medication abortion from online telemedicine services. And we really wanted to understand if this varies by state policy context, meaning parental involvement. We looked at requests made to aid access an online telemedicine organization over time. We started in September 2021, and we looked through October 2023 with special attention to both the Dobbs draft leak and the Dobbs decision. And just a note, aid access sends pills to people without involving a parent. We looked at age, state policy, state abortion ban. And we find that during that time period, over 230,000 people requested medication abortion from aid access, and 6%, about 14,000 of those folks, were under 18. And that requests coming from people in states with parental involvement laws were higher than in states without. And requests were the highest among people living in states with both parental consent and notification laws. These are these states with the stars. So as abortion bans continue to pass and as parental involvement laws stay on the books, adolescents under 18 will continue to face major barriers to abortion care. Further adolescent-focused research is needed to understand how to support these young people seeking medication abortion through online telemedicine. Thank you to my mentors and colleagues and co-authors, Rebecca Gompertz and Jennifer Starling, and thank you to all who support young people accessing abortion care. Thanks.
Hi, everyone. I can only be brief and brilliant if I look at my notes, so I hope you'll bear with me. I'm really happy to be here today to talk to you about my research on the time of discontinuation as a locus for LARC coercion. So I know I don't have to tell the people in this room why the reproductive health world loves LARC so much. They work for a really long time. They have really low failure rates. They're easy to use. They have a lot of advantages. And because of those advantages, it's led some scholars and advocates to proclaim that we're in an age of LARC, or entering a new age of reproductive health centered around LARC provision. And that has led to a lot of these so-called LARC first programs, like this really famous one from St. Louis, the Contraceptive Choice Program, which was designed specifically to promote the use of LARC methods. as sort of a first line contraception with other methods presented sort of second or sometimes not at all. And then, of course, in response to that, there's been plenty of pushback in the reproductive health world based on concerns that LARC-first approaches to counseling can violate reproductive autonomy. So we've had a lot of commentaries and a lot of ACOG practice guidelines issued in response to this concern. But what's gotten significantly less attention than biased counseling at the time of LARC provision is what happens when people want to take their LARCs out. Because unlike shorter acting methods, which are sort of provider independent for a discontinuation, you need a provider to remove your LARC the same way you needed a provider to put one in. And so I've been doing some qualitative research around this topic in an African country that I'm going to keep anonymized for today. And I'd like to recognize my co-author Al Calenda on this work. And so qualitative work is really hard to present briefly and brilliantly, but here's one quote for you. The most important lesson that we learned from this research is that providers really do seem to be taking on a role as gatekeepers to LARC removal rather than viewing their role as removing LARC methods on patient request. So here we have Maddie saying, I used the implant for 3 months and my period stopped coming. I went to see a nurse at the clinic and she told me that I should leave it, that it's normal. I told her that I came to change my method and she told me no, that you cannot change and that you have to continue with it. So the paper that I mentioned is filled with many, many more examples of this. I wish I had more time to sort of show you all the nuances around this, but generally the findings were that women sort of had to prove to providers that their request for LARC removal was legitimate enough to be granted. In our paper, we summarize some of the reasons that our respondents gave for why their providers told them that they wouldn't remove their LARCs. So that included things like an inability to pay for removal, a provider's desire to extend the interpregnancy interval, and sort of to enforce a birth spacing approach, a belief that early removal is wasteful or can be dangerous, and a whole other slew of reasons here. And so if you want to learn more, please check out this article. But the sort of big takeaway here is that LARC methods prevent sort of an extended time period during which coercion can take place, starting at the time of counseling and initial method provision, but going on through the sort of the duration of use until discontinuation. And LARC methods sort of require an enhanced vigilance from us across that entire time period to make sure that we're respecting reproductive autonomy. And so I'll thank the funders of this study and thank you all so much for listening.
Hi, my name is Alex Christensen, and I'm a doctoral candidate in the medical physics program studying quantitative ultrasound. I'm very fortunate to work with a variety of experts in the basic sciences who have all dedicated their efforts to understanding the cervix better and understanding its role in preterm birth. Preterm birth has a physical, financial, and emotional toll, and unfortunately, it's been on the rise in recent years, with about 1 in 10 births occurring preterm. It also has an outsized impact in certain demographics, leading to an imbalanced burden. And without a full understanding of the biological pathways to term birth, preterm birth is particularly hard to predict and prevent. So our group is approaching this problem on multiple scales and in multiple disciplines. On the subcellular level, our collaborators at Columbia University have performed protein assays in the cervix throughout pregnancy, as well as studies of molecular cross-linking of collagen throughout gestation. They've also studied the cellular makeup of the cervix using specialized staining techniques. Moving to the tissue level, our collaborators at the Morgridge Institute have done studies of fetal membranes, as well as the collagen content of the cervix using high-resolution microscopy techniques. Ultrasound can be taken in vivo or ex vivo, and then probed with physics models to give us a better understanding of the microstructure from an acoustic perspective. And the Myers Soft Tissue Lab has taken samples of cervix tissue and done tensile and compressional tests on those. On the organ level, ultrasound can be used to gain macroscopic insights as well into tissue elasticity or the stiffness and softness of the tissue, as well as the development of blood vessels in the cervix throughout pregnancy through Doppler acquisitions. Ultrasound can also be used to gain geometric measurements of different parts of the cervix and uterus anatomy. And these can be fed into predictive algorithms that will show us which ones of these measurements are the most significant in predicting preterm birth. And these measurements can also be combined with those compression and tension tests to give us mechanical models of the uterus and cervix. Now, while the linear pathway from micro to macro is great for summarizing, I think a more realistic roadmap looks like this, where our efforts inform, complement, and yes, often complicate each other. But from these efforts, we've learned some important things. For one thing, we've learned that the cervix is not composed homogeneously of collagen fibers as previously thought, but that it contains a more complex arrangement of collagen and smooth muscle cells, forming more of a sphincter at the internal os. And this finding and others have pointed to a framework of the cervix as an active player in pregnancy as opposed to a passive bystander. In the future, we'd like to be able to take measurements at multiple scales and feed these into models to make predictions about the timing of delivery in an individual patient. To do this, we don't want to stop our considerations at the organ level, but also consider the individual, social, and societal level as well. And through these efforts, we hope to alleviate, not only alleviate the problem of preterm birth, but also to address the paucity of basic science research in women's health in general. Thank you.
We're just going to have a tiny change up this morning to recognize our brief and brilliant participants that, at this time rather than at the end. Given that we have a couple extra minutes here. So if we could have the 4 presenters just come up briefly, we have a little token of appreciation to recognize you all. So we're going to give you guys each a little swag bag, if you will, and there's a certificate here to recognize that you were one of the chosen recipients for giving your brief and brilliant. I thought they were all very brilliant, different topics, and so I'm going to hand these out to each of you. The wrong order.
Christina.
Okay. Just making sure we give you the right answer. Perfect. All right, one last round of applause for our excellent presenters.
Okay, fabulous. And let's just make sure we didn't miss Jeannie Erickson because we don't think we did. Her work is impressive. I just learned a lot and it's just less than a half hour. We're just getting started, people. And having a physicist with us, wow, that's a new one. Okay, so we're gonna go ahead and move forward. That'll just give us more time at the actual break. If you want to refresh your coffee or grab a little bit more food, feel free to do that. I also just want to acknowledge the fact that Hurricane Milton just wiped out the state of Florida. And for those of you in the audience that might have a family or friends there, our hearts go out. My brother and sister-in-law live in the Tampa area, and I have not heard yet from them. I suspect they're okay, but I just wanted to acknowledge that this morning because we need our communities to help support us when things like that happen. Having said that, we're going to move on to this one's going to be a long and brilliant talk. This is our grand round. So for everybody who is online or in the audience that needs CME credits, the text, you can text to the phone number VASPED. So that's VASPED. I have the pleasure of introducing our keynote speaker this year. Her name is Dr. Charlotte Gamble, sitting right there, and you can come and listen to your bio, or you can hang. Yeah. You know your bio. She is currently a GYN oncologist at MedStar Washington Hospital Center in Washington, D.C. Her faculty appointment is at Georgetown University School of Medicine. And for those of you who don't know the DC area, apparently Washington Hospital is like the big hospital, the #1 trauma center where everybody goes for all the complicated things. And MedStar owns every hospital in Washington. So that's what I learned. So she's a busy clinician. She obtained her bachelor's degree in brain behavior and cognitive sciences, and went on to do her MD degree at the University of Michigan Medical School, a Michigander from birth, is what I understand. She received her master's in health policy and management from the T.H. Chan Harvard School of Public Health. She completed her residency in OBGYN at Duke University and her fellowship in gynecologic oncology at Columbia and Weill Cornell Hospitals in New York City in the middle of COVID. So her research is health services delivery, specifically on outcomes for patients who receive gynecologic cancer care at safety net hospitals. She's currently studying barriers to and facilitators for patients with endometrial cancer in the Washington, D.C. area. She's an active member of the Society of Gynecologic Oncology, the National Medical Association, the American College of Obstetricians and Gynecologists, and the American Society of Clinical Oncology. She is a board member of a patient advocacy group called the Endometrial Cancer Action Network for African Americans. She's pretty fabulous. I didn't know her personally before last night, but a small group of faculty were able to meet with her for dinner. She's warm, she's engaging, and I'm so excited to hear her talk on endometrial cancer interventions to address a growing public health crisis. Welcome, Dr. Gamble.
Well, thank you so much for that very kind introduction, Dr. Hardenbach. I'm an honored member to be here. It's a delight to come to Madison. I have family in Madison, and so this trip has been meaningful in multiple ways. And it's just been a pleasure to see the presentations from this morning, and a true honor to be able to share some slides with you today as part of this symposium that has such a rich history. So thank you so much for this honor. I do want to start by doing a land acknowledgement to acknowledge the fact that we are on Ho-Chunk land of the Ho-Chunk Nation, and this land has traditionally been called J-Job. So thank you so much for having me today. I have no financial disclosures, and I will not be discussing any unlabeled or investigational uses of pharmaceutical products. And my objectives are 4. So first, I want to describe the epidemiology and public health impact of endometrial cancer in the United States. And then from there, move on to summarizing some of the rapidly evolving treatment paradigm changes in terms of management of patients with endometrial cancer, to examine areas of historic and contemporary bias and research that may have contributed and contribute to racial inequities in the outcomes that we see, and then also to explain some interventions for addressing these disparities moving forward. So let's start with some epidemiology and public health impact. I went into medicine because of my interest in public health and take my role as a clinician very seriously in being an advocate for public health interventions from a clinician standpoint. And I think it's really important to understand the big picture as we see patients who present to us in our office. When we think about the epidemiology for endometrial cancer, the rates are increasing, and there's been a disproportionate rise of incidence of endometrial cancer experienced by Black patients in the United States spanning for the past 30 years. Everyone has rising rates, but specifically for Black patients, you can see these rates are converging, these lines are converging, and the incidence rates have been on the rise. And I think this very much parallels what we've seen in the maternal mortality space. And I would like for everybody to just acknowledge that there's something going on. We traditionally think of endometrial cancer as it's an estrogen responsive cancer. And so we think that perhaps related to the obesity epidemic, this could be a driver for why these rates are increasing, where obesity is thought to be the underlying cause of 57% of endometrial cancer cases. And for every 5-unit increase in BMI, the risk of endometrial cancer increases by over 50%. And rates are rising in young women, along with the obesity epidemic. Tamoxifen continues to be a bad player. Estrogen-only hormone replacement therapy without a progesterone to protect the endometrium, the inner lining of that uterus, continues to be a risk. Things like diabetes and PCOS, all risk factors. And again, these pictures and stats are taken from a lovely review by Dr. Karen Liu and Dr. Brodus from the New England Journal from 21. But estrogen and obesity, that's not the whole story. The non-endometrioid types of endometrial cancer are rising. So non-endometrioid subtypes of endometrial cancer tend to be more aggressive. These include things like serous cancer, carcinosarcomas, grade 3 endometrioid types that have certain molecular features. And these rates are increasing. You can see here from 2000 to 2015 in all racial and ethnic subgroups, but predominantly also in Black patients. And this is thought to be one of the biggest drivers to why the rates, the incidence is increasing and the mortality rate is also increasing. So we now are entering actually a completely changed landscape of gynecologic cancers. This was one of the articles that was in, I think, the Gynonc CME modules from the past couple of years, published by Dr. Siegel and her colleagues back in 22, which discusses the ovarian cancer mortality rate has been decreasing over the past 10 to 15 years at a rate of 2.4% annually, probably due to PARP inhibitors and some novel therapeutics. Really, really exciting and such a welcome respite from this devastating disease. But at the same time, we've seen a rise in the uterine cancer mortality rates. And this is one of the only cancers in the United States that has a rising mortality rate to it. There is something happening with uterine cancer in this country. And to the extent where we used to think of ovarian cancer as kind of the biggest player, there are more deaths for the first time in history from endometrial cancer compared to ovarian cancer now in the year 2024. So they've now switched in terms of the number of deaths per cancer in this country. And I will note that for Black women, this change actually happened back in 2005. So for the past 20 years, Black women have been living this reality. And now the rest of the country has started to catch up in terms of mortality and incidence. This racial disparity is massive. It's a 20% Black-white racial disparity in 5-year overall survival, the second highest of all cancer types in the United States, second only to melanoma. Black women have double the likelihood of dying from this cancer than other racial and ethnic groups. And even when you adjust for stage and histology, in young Black women, they still have this increased mortality rate of around 20 to 25%. The survival gap over the past 20 years has not changed. This is data from Dr. Rahane when he was back in Boston, actually, where you can see over the past 20 years, it has remained stagnant. White, Asian, Hispanic women generally have survival rates in the 80%. And Black women are, for whatever reason, in 60% when we talk about 5-year survival. And it's maybe not improved, but I think it's actually getting worse. Not I think, it is getting worse, right? So when you think about the disparity gap, when you look back in the 1990s, the mortality rate for for white women was around 4. And when you compare that to Black women, it was 7.2. And now in more recent data, we have that it's gone to now 4.6 in white women to 9.1. So that gap is actually widening over time. It's not just stagnant. And so we're in a real crisis in this country. We don't really know why this is happening. We think, oh, maybe people are presenting with more advanced stage of disease if they wait longer to come to the doctor, have more difficulty in accessing physicians, or maybe they have higher grade tumors and there's a higher rate of these non-endometrioid aggressive types that we don't have great treatment or management strategies for yet. Maybe there's poor access to care. We had a lovely presentations this morning about access to abortion care and thinking about maternity care deserts, and endometrial cancer, Kemi Dole likes to argue, is just another step in the pathway of reproductive injustice in this country. And if you live in a place where you have lacking access to abortion care, also, you're probably going to lack access to gynecologic oncologists and lack access to clinical trials and lack access to obtain novel therapeutics. And so these all are very much interwoven in terms of how we think of women's care and reproductive justice in this country. But even when you control for tumor characteristics and patient characteristics and the treatment type, there's still a gap in survival with a hazard ratio of 1.2. So there's still something that we're missing. And sometimes like to call that the racism gap. The diagnostic pathway is biased. So ultrasound is generally used as a screening test. We know per ACOG, we should think about that endometrial stripe, and less than 4 millimeters is a time when you don't really have to worry that much, and 4 millimeters is when you should biopsy. And so we've all had that drilled into our heads from the time when we were medical students through residency and training beyond. But uterine serous cancers, classically, these are the non-endometrioid types, the aggressive types, the types that disproportionately happen in Black women, can classically start occurring in an atrophic or very thin endometrium, where that endometrial stripe might not be as sensitive as we'd like it to be for these more aggressive types. And we know that having uterine fibroids distorts the endometrial cavity. It makes it much more difficult to actually measure that stripe appropriately. And both of these issues, both the serous cancer as well as fibroids, disproportionately affect Black women. And so we're systematically missing patients using the ultrasound device as kind of a screening strategy. Dr. Dole, who is a mentor and a friend, published this study in JAMA Oncology a few years ago using a simulated cohort of patients and trying to look at the sensitivity of transvaginal sonogram in terms of estimating cancer risk, finding that the sensitivity for Black women is around 47% dismally compared to white women at 87%. And we note that why did we decide to use transvaginal sonograms to kind of screen for endometrial cancer? Where did that even come from? Well, these are studies that were from countries in like Scandinavian countries and Hong Kong and Italy. And when you think about the population in the United States and the population that's disproportionately affected by endometrial cancer incidence mortality, those countries might not be representative of that. And so this screening test that is used widely was developed in cohorts of patients that are not similar to the patients that we see. She recently published just this past summer an actual cohort of patients, premenopausal is the asterisk to this, but still a cohort of Black patients trying to understand, again, this idea of what the best threshold for cutoff and where we should be worried comes into play. And we can still see that if we're using that 4 millimeter threshold in terms of the thickness of the endometrial stripe, it's still got a sensitivity. It's got a sensitivity that's better than the simulated cohort, so it's 90%. That's better, but still a pretty high false negative rate of 9.5. And so I always talk to my referring clinicians and let them know that, you know, just getting a sonogram if somebody's bleeding is not enough. If they're bleeding, they need a pathologic diagnosis, and a biopsy needs to occur regardless of what you're seeing on the ultrasound. So we're going to move into a little bit of the treatment paradigm to talk about kind of what standard of care looks like in the United States, some of the things that have come about in the past few years for the non-GYN oncologists in the room, so you know where the science is at, where the science is headed for those patients that you send our way with endometrial cancer. Still the backbone of how we take care of patients with endometrial cancer in this country is surgical and surgery for those patients who have uterine confined disease, low risk disease, non-aggressive subtypes can be curative. And this includes a total hysterectomy, so removal of the uterus and cervix, removal of fallopian tubes, removal of ovaries. Sometimes in premenopausal women, we allow them to keep their ovaries depending on some certain risk factors. We take out lymph nodes and do some ultra staging of sentinel lymph nodes, and so see where if we can take out a few lymph nodes as opposed to doing full pelvic lymph node dissections to decrease perioperative complications, and then some additional additional staging procedures if it's deemed necessary based on the patient's pathology. And we try to do this all minimally invasively, right? So a robotic approach or traditional laparoscopy, which minimizes patient stay in the hospitals, minimizes their perioperative complications, and we know has the same long-term oncologic outcomes as the open laparotomies. When we think about how the inequity literature dovetails with standard of care therapies for patients with endometrial cancer, there are large inequities at hand, right? So Black patients are less likely to undergo these minimally invasive surgical techniques, even when you control for things like stage and histology. Even when Black patients are referred to high volume hospitals for hysterectomies, they're more likely to see low volume surgeons within those high volume hospitals. We know that when patients seek care at public hospitals as opposed to private hospitals, they wait about a month longer for their surgery, which from a cancer standpoint absolutely can have an impact on survival and stage. And we know that Black patients are more likely to receive surgical care at community hospitals even when they live closer to an academic hospital. So we can dive into that. This is work from Dr. Dimmick at Michigan, published maybe actually 10 years ago at this point, where they looked at patients, this is all comers for general surgery, who lived adjacent to academic hospitals, and in highly segregated neighborhoods, the Black patients in those segregated neighborhoods went to community hospitals. They did not go to the nearby academic hospital. And so to think about how we have inequity baked into our system. So yeah, hysterectomy and BSO is the standard of care, but who's actually getting it? Where are they getting it? Who's doing their surgery? And where are they seeking their care? These are all really important questions to ask as we acknowledge what the standard of care is in this nation. Now, when we think about adjuvant therapy, so the concept of adjuvant therapy for the non-gynecologic oncologists in this room, so hysterectomy will cure a lot of patients from their endometrial cancer, but for some patients, they might have some high-risk factors that they need additional therapies that come either before or after hysterectomy to help get them into remission, to help really cure them of their disease or get as close to a cure as possible. And prior to 2023, that looked like chemotherapy for patients who have advanced stage 4 disease. It looked like a combination of chemotherapy and radiation therapy for those with stage 3 disease, and some smattering of radiation for some high-risk early-stage disease patients. And of course, at every step of this pathway, Black patients received less often the standard of care therapies and recommendations. Now, as of 2023, everything is completely on its head for how we think about endometrial cancer and the adjuvant therapies that provide with the role of immunotherapy. So drugs like pembrolizumab, dostarlimab, and all of these mAbs that some of the trainees might be a little bit familiar with. And we're really using immunotherapy a lot more in endometrial cancer. We know this from, this is my only GYN oncology very, very specific trial with the trial name, so I will spare you the rest of this, but these trials that have happened over the past 5 years have really looked at how we can use immunotherapy to gain really amazing survival benefit for patients with endometrial cancer. So we now use it in what's called a microsatellite high cancers. So these are cancers that have what's called mismatch repair. It's a certain type of cancer, endometrial cancer, that responds really, really well to immunotherapy. We started using it there first. Then we started using immunotherapies based on Keynote 775 trial in the recurrent setting. So when cancer comes back, now immunotherapy is very much a part of how we treat recurrent endometrial cancer. And then 2 trials that were published or presented last year, the Ruby trial and GOG 018, have now shown a significant impact in actually moving immunotherapy in the upfront setting for patients with endometrial cancer. So now using immunotherapy is after a patient gets their surgery, if they have certain high-risk factors of their advanced stage, they get immunotherapy alongside their chemotherapy. And it's really exciting. It's completely transformed how we deliver care in the United States. And then there was one trial, a phase 2 trial that was published earlier this year / late last year that has now shown a benefit in a very specific targeted agent called trastuzumab deruxtecan. And that works really, really well in certain subtypes of endometrial cancer. So there's been a huge paradigm shift towards more targeted therapies and immunotherapies in the past 5 years. How does that dovetail with inequity? Well, in these trials, where are the Black patients? In Keynote 158, race was not reported. There was only an N of 74 patients, but race was not even reported in that trial. In Keynote 775, which was a worldwide trial to look at immunotherapy in recurrent endometrial cancer, Black patients comprised 3.7% of the total trial enrollments. Less than 40 patients out of 837 were Black. In the Ruby trial and the GOG 018, we had better representation, around 12% of the cohort, which I would argue that that's still not sufficient, because if you think about the incidence and mortality rate, who's disproportionately suffering from this, we should be oversampling Black women on this trial and not okay with just kind of knowing, oh, this is in par with the population statistics in the United States. We need to be oversampling Black women to understand how this how these new drugs can work. And the Destiny trial that was just published with this very exciting data didn't report the race outcomes either. And I'll spend a note kind of talking about the role of how we think of this mismatch repair deficiency, right? And so I mentioned that immunotherapy works really, really well in certain subtypes of patients with endometrial cancer, and mismatch repair deficient endometrial cancers respond well to immunotherapy. You can see these beautiful survival curves, and you can see these for the statisticians in the room, the hazard ratios just being completely astronomical, just amazing survival benefit. At 2 years, you have 83% of patients alive with endometrial cancer, compared to 58% if they didn't get the immunotherapy on board with their chemo, with a hazard ratio of 0.3. And you can see that that's incredible. In the overall population, you still get a survival benefit with a hazard ratio of 0.6, but it's just not as significant, not as groundbreaking as a hazard ratio of 0.3. What we also know, though, is that Black women are less likely to have these mismatch repair deficient cancers. We know this based on kind of anecdotal evidence for a long time. And finally, the group at Memorial with Dr. Weigand and Dr. Brown published this last year, where we are seeing that white patients are much more likely to have mismatch repair deficient cancers, and Black patients are less likely to have mismatch repair deficient cancers. So what happens if you have an agent that works really, 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 really well for mismatch repair deficient cancers, and Black patients are less likely to have mismatch repair deficient cancers? I suspect we're going to get, and the literature is soon going to show us, that we're going to have a widening disparity in a cancer that already has a really significant survival gap. And I worry that that's going to be what we'll see in the next 5 to 10 years. Something that I do, even though they never reported the rates of the racial breakdown from this data, I am excited for this data from the Destiny trial that looks at just some, again, really significant survival benefits with this new targeted drug for HER2 positive cancers. And the reason for that is that Black women disproportionately have uterine serous cancers with HER2. And so there might really be a role where this starts becoming a transformative agent for Black women with these high risk cancers. So this is something that's new, is exciting, and I'm excited to see where that goes. So now that we've talked about kind of the incidence, the mortality rate of endometrial cancer, the standard of care, and kind of the biases we've had in our clinical trials, I really want to move towards kind of understanding the equity component, the public health component to this. Thinking about poverty is really where we have to start. And when we think about how poverty dovetails with kind of American culture, it's very much baked into like how we live and breathe as Americans. 38 million Americans live in poverty in the United States, and that's defined as having an income of less than $15,000 for a family of one, $20,000 for a family of two, and $30,000 for a family of four. It's really the sustained exposure to living in an impoverished neighborhood that starts to affect healthcare outcomes like diabetes, heart disease, stroke risk, and some work in the cancer arena, which I'll get into. When we think about how this has changed over time, the poverty rates in America have been increasing over the past 30 years. And you can see some fluctuations. And the presenter this morning that had this slide on the rates of preterm birth, I was noticing that because that directly mirrors the rates of poverty in this nation. You can see around the recession, the rates of preterm birth rise as the poverty rates in the United States have risen. And so when we talk about equity in this country, poverty is that underlying driver of a lot of that then disproportionately affects marginalized and minoritized communities, right? And so it's really important to start by understanding that concept of poverty and how patients are coming into our offices with this reality and what we're going to do about it. It's also important to understand the concept of intersectionality, which I'm sure many of you in this room are familiar with, but then how does the idea of poverty, and specifically concentrated poverty. So concentrated poverty is where you have more than 40% of people in a certain census block group that live below that poverty line threshold, as opposed to just the low income area, which is 20%. So living in a very, very poor neighborhood, what does that mean? And what does that mean for people who are Black or Hispanic in this country? For white Americans, 1 in 13 white Americans will live in an extremely poor neighborhood. 1 in 6 Hispanic Americans and 1 in 4 Black Americans are going to live in an extremely poor neighborhood in the United States. And we know that once you live in a really poor neighborhood, it's hard to get out. So 2/3 of Black Americans that are brought up in these poor neighborhoods are there a generation later. 40% of white Americans who live in these really poor neighborhoods are there a generation later. You cannot leave. And again, it's this sustained exposure to poverty that starts driving these healthcare outcomes. When you control for parental income, Black boys still have lower incomes than adulthood than white boys in 99% of census tracts. And so you think about who our Black patients are coupled with. And when you think about the disparities in income and where they live, I have been fascinated to think about how place, I was really disappointed that the last speaker today, who is going to talk about place and environmental health and neighborhood, that was like my topic. And I was really excited to hear her talk. But how does place and neighborhood affect health? And that's really been a question that I've had since I was a medical student, thinking about equity issues in Detroit, and how the neighborhood that you live in Detroit can determine the trajectory of your life, the trajectory of your children's lives, and your healthcare environmental exposures and outcomes. A really lovely resource for this came out of the University of Washington, or the University of Wisconsin here, with the work of Dr. Amy Kind, which hopefully most of you are familiar with. She's a PhD scientist, really well-funded NIH researcher, that has now made accessible the use of a score called the Area Deprivation Index. And this is a way to be able to quantify poverty, and to rank poverty against neighborhoods against one another, to look at an index to see within a state level, within the national level, how the census block groups measure up to one another. So it takes weighted components from the US Census. This is a score, an index that was developed in 2003, and takes these weighted components, weights them, provides an index, and then is able to provide a national or a state-based rank. And I like to use this in defining the most affluent neighborhoods or census block groups as the wealthiest 20%, and the most vulnerable neighborhoods as the poorest 20%. And we did some of that work in New York State, where we tried to see how did these impoverished neighborhoods intersect or interlap with ovarian cancer, endometrial cancer outcomes. So we actually were able to find between 2004 and 2017 some cancer statistics through the Cancer Registry in New York State. We found where patients were living at the time of their diagnosis and mapped that to their area deprivation index score, and then linked that with hospital linked data, and found around 34,000 patients that we were able to link all their health outcomes with the neighborhood in which they were diagnosed, and see what their outcomes were. We found that for patients who lived in economically vulnerable neighborhoods, they had lower rates of chemotherapy that was stage-based chemotherapy recommendations. They had more surgical delays. They had worse 5-year overall survival. And we really appreciated this more so outside of New York City. We stratified our analysis by New York City and outside New York City, since they're so vastly different in terms of geography and population density. And we found these statistics were much stronger outside of New York City when you're looking at rural areas or non-metropolitan areas. And New York City was a little bit messy when it came to some of these statistics. But what New York City did allow us to do was use the wealth in terms of the diverse patient population in New York City to understand how race and poverty overlap. And what we found that was there are racial disparities at all levels of socioeconomic inequity in all neighborhoods in New York State and New York City. But when we thought about where the gaps were the widest, we actually found those to be in the wealthiest New York neighborhoods. This is a graph that we used. Sorry, the hazard ratios aren't lining up there, but you can see how the widest gap is in these wealthiest, affluent neighborhoods in New York City for patients who have high stage disease. And this is really driven by the fact that you see that horizontal red line in the bottom for Black women. It doesn't matter if you live in a vulnerable neighborhood. It doesn't matter if you live in a wealthy neighborhood. You still have the same terrible survival. As compared to white women, for whatever reason, as you live in a wealthier neighborhood, your survival improves. And so we see this widening disparity in really wealthy neighborhoods. And that begs the question, what else is happening? Even when you control for stage and histology and treatment and all these other factors, that disparity gap is still persistent. It's still statistically significant in these wealthy neighborhoods. And why don't Black women gain that same survival advantage if they move to a wealthy neighborhood? What is going on? I think it's important to understand that our work here is should be grounded in the patient experience. And for a long time, clinical trials and a lot of the research that comes out of our really esteemed journals the questions have been asked by us. We're asking the question. I say us, I mean physicians and PhDs and very educated people, right? And we've been asking the questions and we've been seeking the answers that we think that we need to answer the questions we've asked, but patients are actually at the center of this. And for far too long, they've been missing from our research teams. They've been missing from actually our research questions in a meaningful way. Recognizing that they're the experts of their own experience, there've really been not very many qualitative studies that have been published, a lot more of the past couple years, which I've been really excited and pleased to see. Kimmy and I worked together to do a qualitative analysis on social support in endometrial cancer and use some focus groups of patients with endometrial cancer to understand their experience and how their experience can maybe drive some research questions in the future. Finding some themes of emotional burden, so uncertainty, loneliness, a sense of loss, anger, financial distress, as well as a sense of resilience, development of agency, transformation of self, the responsibility to champion awareness. When we think of the actual words of these patients, so that I think it's important to mention, you get all this attention when you're in treatment. You have direct contact with your doctors or your nurses, and then you have a group of support people that are around you during your treatment. And then this patient was talking about when she comes out of treatment, it's like falling off of a cliff. Oh my gosh, my body, what happened to it? Someone describing their experience after what was an uncomplicated hysterectomy. What happened to her body? They want their copay from the last time you were there. It's very expensive to be sick. Every time you go, you've got to pay for your parking. And I had a sense of helplessness, of not having the family support, the religious support that I should have had. None of this was in any of my prior slides. This is what patients are saying, right? They're not necessarily talking about the rising rates, the incidents. They're talking about, I can't pay for my healthcare. I have to pay for parking, which is really annoying. And after an uncomplicated surgery, or what I would consider as a surgeon, a very uncomplicated surgery, my body, it totally changed what happened to it. Agency, transformation, responsibility. So I just started loving me since I got diagnosed with cancer. I thought I did, but I really didn't. It was all a fat lie. I want to be able to sit next to somebody to say, girl, I know where you've been and look where you're going. I'm militant now about this community, about our African-American sisters getting this treatment. And I want to be here 10 years from now. And 10 years from now, I want to know her, a survivor, even better. That is surviving. Seeing your life really through other people. So when we think about what happens to patients after they go on their 2 to 3 years of immunotherapy, what is that survivorship like? What is their experience like? Where do they go? Where do patients go? I was telling them, goodbye, you're cured of your cancer, go have fun in the community. Who is in their support network and who is surrounding them? And how can we use the patient experience to improve the future patient experience moving forward? Whenever a patient comes into my office and I'm talking to them about their new diagnosis of endometrial cancer, and what to think about and kind of setting the framework for the next 4 to 6 months of their lives. I'm talking to them about resources like the Foundation for Women's Cancer, which is a partnership between the Society of GYN Oncology and as well as patient advocates that has really lovely resources online. There's Share Network, which is a patient-driven support network and online community, as well as the Endometrial Cancer Action Network for African American women, which I'll talk about in a moment. But I think it's really important to set the context of survivorship networks as being critical to patients' well-being. So the Endometrial Cancer Action Network for African American Women, founded by Dr. Dole back in 2018, has been a remarkable and transformative group of patient advocates, and it's entirely patient-driven, patient-run. Dr. Kemi Dole used to be at the forefront of it, and she's given it now fully to the patients who are leaders in terms of advocating for the community. There's a huge online presence, and there are local groups that are active. They provide social support for patients through the online sphere, having sanctuary Sundays where patients are able to join online group to help with meditation and mindfulness. And there's a little bit more of a sense of community, because oftentimes what we found based on our qualitative work, based on patient stories, was there's an incredible sense of loneliness after a diagnosis and during treatment. And so this group has been transformative. And then Dr. Dole has been doing the sister study over the past couple of years. We have a site open at MedStar Georgetown in DC to randomize patients to figure out what's the best support structure that we can have for patients after they've received a diagnosis of endometrial cancer. We can't just give them their chemo and say, good luck, have a nice life. We should probably give them some additional support. So randomizing patients to either one-on-one peer support, randomizing patients to a group of peer supporters, like a centering pregnancy group per se, and then enhanced usual care. And so this study I think will be wrapped up with accrual next year, and then the results from that we hope to see in the future years to come. And then when we think about interventions to build equity, so this is a part that I'm going to spend a lot of time on talking about. We know where we've been, we know what the standard of care is, we know what patients are saying, what can we actually do? And we worked on doing a narrative review for this, thinking about all the reviews and a lot of the editorials we see is just talking about the incidence, the mortality rates and the public health impact. And that's all fine and good, but we need to actually do something about it. And most folks are familiar with the MLK quote of the arc of the moral universe bends towards justice. And then the asterisk to that is, but only if we bend it, right? And so from a research community, where are we on this arc? I would argue that we've been describing disparities for a really long time. We're probably pretty good at that. I think we're set. We can do a little bit more if we really want to, but that's fine. We're probably in the understanding inequity phase, right? Of trying to understand why these inequities persist. Why are there different rates of endometrial cancer? Why are there different mortality rates? And understanding some of the causes. But we're nowhere near eliminating inequity, developing and piloting interventions. We're not doing that. We're not publishing on it. We might be doing it. We're definitely not publishing that data. And then we're remote from achieving justice, right? To adapting policy to actually fit the interventions that we know are evidence-based. So we've got a long way to go on this curve to be actually able to enact change. I love the socioecological framework. I kind of use this in my day-to-day living. And I think it's really a good way to kind of set an understanding of how we can organize these interventions. And it can get very overwhelming very quickly, right? So you think about the policy level, and this list to the right is not meant to be comprehensive in any way, shape, or form, but are just examples of how we think about interventions that can fit into these levels of our society. So in the policy level, advocating for equitable NIH funding and advocating for equitable insurance marketplace and coverage, the community level, building community partnership and addressing the social determinants of health, organizational level, establishing care navigation and medical legal partnerships, as well as diversifying our clinical trials, At the interpersonal level, amplifying patient advocacy groups, partnering with faith-based organizations, and at the individual level, creating educational programs and engaging in media campaigns. You'll note that I'm not saying that, oh, patients, it really is, the onus is on the patients to come in sooner and do all these things sooner. I think as healthcare providers, we should listen to our patients, see what's necessary, and then build systems and structures that make it easy to access care, make it easy for them to seek care, and not say, oh, she just delayed and didn't come in for a year. Maybe it was because she was dealing with a sick husband or a sick child, right? And how can we make the lives of women, the lives of people with a uterus, a little bit more so that the default is to seek care sooner when there's something wrong. So when we think about macro changes at the policy level, this includes things like Medicaid expansion, which I know that Wisconsin has so much experience with, NCI funding, National Cancer Institute funding. There's some acts of Congress, so the Clinical Treatment Act passed in December of 2020, which included Medicaid coverage for clinical trial participation and real referral patterns and regionalization and how to centralize cancer care, right? And I would encourage all the trainees in this room to really strongly consider attending the ACOG Congressional Leadership Conference that happens annually every March in Washington, D.C., which is your opportunity as clinicians and providers to advocate for your patients. And from this conference, there have been several acts of Congress that have passed and several things that improve maternal health care. This is why now there's Medicaid covering 12 months postpartum for patients as opposed to 6 weeks postpartum. That's a direct result of this Congressional Leadership Conference that is an annual event by ACOG every March. And I would really encourage everyone in this audience to be able to attend and advocate and speak with your Congress people about changes you need to see. So let's dive into a little bit of NCI funding and how money drives a lot of what we're seeing. It drives everything in this country. So you can see here the millions of dollars that are allocated to cancer research from the NCI on an annual basis from 2015 to 2020. And you can see where the gynecologic cancers fall in the second half of the list. And you can see where uterine cancer falls second to last. And so it should be no surprise that then we're facing maybe a public health crisis if we haven't thrown money at a problem. And there's no way for us to expect it to change if we've had the same stagnant rates of funding of this cancer for the past 10 years. Lovely research coming from this department, again, looking at how the disparities in the allocation of research funding to gynecologic cancers can be described by funding to the lethality scores, where Dr. Spencer partners with Dr. Rice and their other colleagues looked at the funding statistics from the National Cancer Institute and overlaid that with the lethality, the mortality of a cancer to try to understand the equity of cancer funding from the NCI. And their findings were really interesting. Where you can see that prostate cancer has been really funded very well for a long time, and every single cancer should be funded like prostate cancer. And it's the top of the list. And you can see then the gynecologic cancers, again, comprising the second half of the list. And uterine cancer is the least funded of all the gynecologic cancers. And so, of course, there's not been a lot of research in the endometrial cancer space. And of course, we're seeing worsening public health trends because there's not been a lot of money thrown at the problem. When you think about the trends over time, there hasn't been improvement in the funding of gynecologic cancers. In fact, for cervical cancer, maybe there's a little bit of a decrease in funding. You can see prostate cancer lost its shine, has been not as well funded over the past couple of years, and melanoma now has risen to the top, and we'll get into that into a second. But by and large, the gynecologic cancers have received the same or maybe a little bit slightly less funding over the past. This was data from 2007, 2014, again, out from this wonderful department. But maybe it's changing, maybe. The HR 2617, it was the omnibus bill passed in 2022, increased funding, the NIH by $2.5 billion, the NCI by $408 million, the FDA by $226 million. This, of note, the omnibus bill there was a lot of really great maternal health care initiatives in this bill, so a lot of great maternal health care things that are moving the needle. And the Office for Research on Women's Health had special funding announcements in 23, and we now know the White House has a special research announcements for additional funding as part of kind of Joe Biden's initiatives. But I do caution that it's not just throwing money at a problem that might fix things. And in fact, if you throw too much money at a problem and you're not mindful of inequity, you actually might worsen things, right? So we can learn a lot from the melanoma experience, where you can see, you saw on the prior slide how they were at the top of the list right here. So they gained a lot of funding from 2007, 2014. And went from 97.7 million in 2007 to 26.2 million in 2014. And during this time, there was multiple phase 3 trials, there are new drug approvals, and there was a 6% reduction in mortality between 2013 and 2017. So really incredible to see that transformation in both of the funding as well as the trials. And then you got to reap the benefits of the reduction in mortality. But who actually got the trials? Who got the off-label use of those novel therapeutics? Disproportionately patients that were white, disproportionately patients that have access to resources, disproportionately patients that could get care at institutions that were offering these clinical trials and getting care with oncologists that were prescribing these novel therapeutics and maybe muddling their way through the prior authorizations of getting an off-label drug use, right? And now melanoma has the widest Black-white mortality rate in all cancers in the nation. So it's not just throwing money at a problem, it has to be coupled with an equitable approach, right? So thinking about, okay, we're doing all these fancy clinical trials, really exciting, we're gonna decrease the mortality rate, but who's being left behind? And that's part of some of the work that I had done in safety net hospitals, thinking about where patients are seeking their care. And if you don't have an infrastructure to support clinical trials in your safety net hospitals, then disproportionately the patients who are seeking care at safety net hospitals are not going to be enrolled in your clinical trial and are not going to benefit from the mortality reductions that we have in our novel therapeutics. So when you think about micro changes and what can happen at an organizational level, the partnerships between providers and community leaders is really important. When you think about outreach and bringing the providers to the patients, that is really critical and important. The role of care navigators and how navigating a very complex and increasingly bureaucratic health system, how that can be transformative to patients, and how we really need to think about the role of segregation and desegregating our clinics based on insurance types, and again, where patients are seeking their care. So Black women are missing from these clinical trials. We discussed this time and time again. I've had multiple slides on this in our presentation. And the biggest factor we know is that they're not offered clinical trial enrollment. This is lovely data out of Alabama that then showed, okay, what are we going to do about this? Like, we know maybe we're just not talking to them enough. And they used the role of care navigators and developed a lay navigator program, having community members and master's degree students in their clinics to be able to speak to all patients about clinical trials. And they found that after they did that with the use of care navigators, that the mortality gap that they had previously seen in their outcomes completely was eliminated. So these are interventions that work. We know this based on the colon cancer literature. There's a really lovely, I think it was published in 2013, 2015 work from the Delaware Project, where they had a multi-level approach to colon cancer screening mortality, using navigators at every single step of the pathway in primary care clinics and the cancer clinics in hospitals, deep in the community clinics. And with those care navigators, coupled with a program to get people in for colonoscopies and make sure those colonoscopies were free, they completely eliminated the Black-white mortality gap in colon cancer in the state of Delaware. So it's possible, we can do it. We need to be offering these clinical trials to patients, but we also need to make sure that the patients are getting care where clinical trials are offered or bringing the trials to the patients. I'm really interested in how we think about care navigation, right? Sorry, that's a little bit cut off right there. This is a lovely review article by Dr. McKinney and their colleagues published back in 2018 that looked at how we think about care navigation in women's health. So in the cancer world, we've recognized for the past 20, 25 years that care navigation is really important. It started from clinics in Harlem with a breast cancer surgeon that realized that if they paired someone in the community that understood the healthcare system with a patient, patients did better. So we have essentially taken this from the breast cancer team. And the cancer world has recognized this to such a great extent that it's a requirement now to be an NCCN designated site that you have to have lay navigators or care navigators as part of your cancer team. But what about pre-diagnosis? right? When somebody receives a cancer diagnosis, the troops swoop in and we wrap them up and we've got all these things they can now access, and we're going to really get everybody together and make sure they've got all the support. But what are the majority of patients in this country that before they receive a cancer diagnosis, how are we helping them navigate the system? How are we helping them recognize that their abnormal uterine bleeding is, or their really heavy periods, or the spotting that they're having after sex, or like when their period came back at age 65 is not normal? Right? And how we think about educating our communities. And I think there's a huge role for lay navigation in that to help raise awareness in our communities and make sure that folks are seeking the care in a timely fashion and are able to do so in the context of their lives. But how do we operationalize this? How do we pay for it? Where do the navigators sit? Who's going to reimburse their work? Right now, the onus is specifically only on clinics and health systems if they recognize this is a priority. And there's no other incentive that we have in our health system to actually make the changes that are needed. And so I think it's this is an area of my own interest that we'll be looking at DC to really try to integrate care navigators into a benign GYN oncology or benign GYN space. And there's probably some role for lay navigators within the obstetric space as well. And lastly, I want to end on thinking about segregation in our health systems and our hospitals, and recognizing that in America, we've segregated patients for a really long time in various ways. And sometimes it's in ways that we don't even realize, right? So I grew up in systems where the residents and fellows had their clinics, and then the faculty practice had their clinics. And the patients who we saw in our resident trainee clinics had Medicaid insurance. And the faculty clinics were well-insured patients with private insurance. And when you think about what that means in America in the context of our lives, how does that separation of patients based on insurance type alone actually is just another method of segregation? And how our systems and structures and hospitals are set up with that a priori. And I will always argue that if we're okay with the, if we think that patients are getting the same level of care in these two clinics, and I think trainee clinics are imperative and necessary. Don't take this out of context. I think they're necessary, and I learned so much from my clinics. But if we really think that we're then delivering the same level of care, then why does it have to be separated by insurance type? Just then put some privately insured patients in a resident clinic and see how that goes. And if we think that it's going to be all fine and good, then that's great. Then maybe we should do that. And if we are uncomfortable with that thought, then what makes us so comfortable about having patients who are insured by Medicaid or underinsured in resident and trainee clinics as compared to faculty-based practice? And so that's something that we can do in our own lives. There's a really lovely editorial in the New England Journal back in 2021 by a colleague of mine, Dr. Vinegar, out of Los Angeles, that talks about kind of this pathology that we have in our health systems and how we think of county hospitals as being really great places to train because you see all of the high acuity issues, but who's disproportionately there, what patient populations are disproportionately represented in these hospitals is really important to understand as drivers of inequity, and how we in the health system are partially responsible for these widening mortality gaps and these terrible health statistics that we started this presentation with. So, in conclusion, we have talked about how endometrial cancer incidence rates are rising. The mortality rate, the number of deaths has now overtaken the number of deaths from ovarian cancer in this country. That we have massive black and white racial disparities that have been well documented, that are multifactorial, that we don't fully understand, and that there's a rapidly changing paradigm for adjuvant therapies with immunotherapies and targeted agents that really needs to be very closely monitored for how patients are going to be disproportionately benefiting from these novel therapeutics and new modalities, and how we need to work on addressing some of the clinical trial enrollment issues. and the need to center Black patients, to center vulnerable patients. I obviously spoke a lot about racial inequity in this talk, but I think it's important to understand that Black women are probably just the tip of the iceberg. Things tend to just happen to us first. And once they happen to us, then it starts happening to every people. So, right, so this has, when we think about it, having a gender inclusive community, right? When we think about patients who are Hispanic, when we think about patients who are immigrants or undocumented, patients who live rurally, patients who have low income, all of these equity issues hit all of these patients. When we think about women compared to men, right? We live in a world where we're taking care of generally women or people with a uterus, right? And when I talk to my husband, who's an orthopedic surgeon, I realize, oh yeah, they're men. Yeah, they're like, there's men, right? And so yeah, like there's disparities when I think of the whole patient group that we are taking care of systematically marginalized in this country. Our entire patient population has been marginalized, right? When you think about the context of that. So already all of our patients are vulnerable, right? And centering the most vulnerable patients is really important in our work. We need to fund our endometrial cancer research. We need to focus on interventions that we know work and try to fund them, diversifying our clinical trials and desegregating our clinics. So with that, I will take any questions. Oh, I wanted to mention one of my favorite books. Again, Wisconsin is a driver in all of this, Evicted. If folks have read this, I would highly encourage you to spread the word. It's a book by Matthew Desmond out of the Milwaukee experience about patients and the housing crisis and how eviction rates and how stabilizing and destabilizing it can be to live in a city where your own housing cannot be certain for days on end. This is one of the most powerful books I've ever read. Talks a lot about how poverty influences every single sector of American life and how healthcare is then completely not even prioritized by patients. And a really, really powerful read as a physician, scientist, and public health practitioner. So thank you for your time and attention. I will be happy to take any questions. Yes, sir.
So people online can hear you.
Oh, I was wondering at your institutions, do you have are you seeing or do you have a BMI cutoff for your patients that receive surgical intervention?
We do not. We do not.
Because I know at times, you know, we'll see that at different places, and that's good to know. The second question I had for you is when you're talking about low volume surgeons, what is your definition of that? And why do you think that would be such an issue given such a highly trained specialty?
So it's in my slide, it should have been hysterectomies in general and not gynecologic oncologists. So that's a misnomer in the slide itself. But low volume surgeons is defined as less than 10 hysterectomies per year. And so if somebody's doing less than 10 per year, we know based on the literature, there are higher rates of perioperative complications. And when patients are seeking hysterectomy, when they get it from a low volume surgeon, not great things follow that. And again, the slide is a little bit of an error because it should have said gynecologist as opposed to gynecologic oncologist. So gynecologic oncologists, by and large, are going to be high volume surgeons. But when patients are seeking hysterectomy care, the hysterectomy numbers of their surgeons was really important, and patients don't really ask that.
I wanted to start with, that was an incredible talk, and I have so many questions, but I'm going to start with those.
Thank you. Thank you. I will add an anecdote for your BMI question. I was literally on a text chain this morning with some of my friends when we think about, again, reproductive justice, right? In the REI world, angry that in REI clinics in general, for a lot of places, there is a cutoff of BMI of 40. But that is not backed by science. That is not backed by ASRM. ASRM actually states unequivocally that BMI should not be a cutoff for assisted reproductive technologies. But by and large, if you survey multiple practices, BMI is a cutoff, right? And so when you think about the reproductive justice spaces, people can't get assisted reproductive technologies if they have an elevated BMI in the private practice community. So it definitely is an issue.
Dr. Gamble,
Yes.
as an REI, thank you for that comment. I am Bala Bhagwat, and I have to commend you on this absolutely eloquent and wonderfully educational presentation. I thoroughly enjoyed it, learned so much from it. Maybe I have to address that criticism first, unintended as it may be. The BMI cutoff is not due to our restriction on providing care, fertility care. It is really due to the restriction that most of the clinics are standalone clinics.
Yes.
And to do egg retrieval, we do rely on our anesthesia colleagues, and they are understandably reluctant to put people under propofol without any anesthesia machine in the building, additional anesthesia support in the building. So we are the OBGYNs, ACLS certified, their backup for whatever it may be worth.
Yes.
So that's truly the restriction.
Yes.
And the BMI of 40, as you point out, it may be arbitrary, but that's what the anesthesia community imposes on us, and that's where that comes from. But what I wanted to share with you is the concept of the care providers that you talk about. I have one anecdote myself. I was taking care of a young, extremely educated, well-listed Black couple whose the wife had bilateral hydrosalpinges that needed to come out. And I was not able to convince them over a course of a year that until they come out, their fertility potential is unfortunately decreased. And at the end of that year of constant meetings and trying to educate them about that and doing all sorts of other treatment, they shared with me, doctor, we think we can be frank with you. It's because you may not know the history of Black women having their tubes taken out in this country, and that's the reason we are very reluctant. And to say the least, I was incredibly shocked, like so shocked, because that's not what was in the back of my mind as I'm trying to understand this couple's reluctance. And I had thought about that incident many times. And when I meet other patients who are reluctant for things that I don't understand, I always think about what is here that I'm missing, what's underneath this, the generational and ongoing trauma that's gripping this country. So I think that's very important for us to recognize and always ask ourselves when you have these, what we think is difficult patients, as what am I missing in this?
Yeah, thank you so much for that comment. I think it's really important we kind of theoretically understand the idea of cultural humility. And we were talking a little bit about this last night of just what does that mean on an individual level with a patient encounter, right? A lot of these interventions I mentioned can be big public health interventions, policy level, but on a day-to-day basis, it's understanding the context of our patients' lives and understanding the mistrust that has happened or the lack of trust that we've engendered in our patients with the institutions that we are working at or the health system at large. That so many times it's patients bring these experiences to us in the context of what you mentioned as trauma of their reproductive tract and working with them. They have to feel listened to. And it sounds like this patient ultimately felt listened to, that they were able to share their fears and concerns. And that's a charge that we have that we should be teaching our trainees, our medical students, our residents. We don't really spend a lot of time on. Like, how do you listen to a patient in the context of their lives? In the context of your life, which is you have 15 minutes to see that patient's door to door, right? And I think there's no way to really incentivize that aside from our own humanity to be able to spend the time that's needed to get to that history that might take a little bit longer than what you're going to be reimbursed for by their insurance company. And that's really, really challenging work, but at the crux of so much of the work on physician bias. Thank you.
Hi. Thank you so much for this. It was just a phenomenal talk. I think I just felt seen in many different ways in this. I wanted to, I think, as I was sitting through this, I was really thinking about this book by Harriet Washington. It's called Medical Apartheid. And kind of one of the chapters, it talks a lot about just the origin of the speculum. And so I know you talked a lot about the importance of patient experiences, how like physicians can really think about meeting folks kind of where they're at. And in this process, I also thought about how you began the presentation around if someone's bleeding, you do a transvaginal ultrasound instead of doing a pathology report. And so I'm curious, in the same way that segregation or inequities are built into our neighborhoods, how do you think about the way that medicine is sometimes practiced? Some of the practices that are embedded in the way even thinking about BMI and how you think about bodies or think about these metrics that are used to make decisions and how they are shaped by these, longstanding apartheids in medicine, inequities, racism, slavery that has kind of like built and been etched in the way that people practice medicine. And so I'm wondering how you think about that, especially as a practitioner, especially as you're these methods and approaches to really thinking about diagnosis and whatnot. So
Yeah, what
thanks.
a deep, profound question. I think people do whole PhDs on this, right? And that book is amazing. So Medical Apartheid, really incredible. Another book that's really great is Killing the Black Body by Dorothy Roberts, who's now a MacArthur Foundation scholar. So really, really lovely reproductive justice books that I should add to this final slide. I think about this a lot. I think about it so much in terms of, now that I'm out in practice for a few years and how I was trained and what I'm seeing on the ground, right? So when you're in resident mode, you're in training mode. Yes, ma'am, no, ma'am, I'll do this. I'm running from room to room and just like trying to gather the medicine as you go, and reading on your text, falling asleep on your textbook, right? And not really questioning the whys, not really questioning, but like, why do we do it this way? Or like, why do we not offer pain medication for transvaginal procedures? Like, I just said what my attending said, which was, the procedure will be over before you know it, and so it doesn't make sense to give you a block or anything like that. I just repeated that, but I don't know, why are we doing it this way? And I think that, again, it's really challenging, and it takes, again, the idea of cultural humility. So not from like a racial ethnic standpoint, but just like the culture of medicine. To recognize that when you're going into a room with a patient, like there are two experts in this room. There's you and there's the patient, right? And recognizing that the patient is the expert at themselves and the expert at their experience and the expert of their own history is, we think, that one of the first steps we can do in terms of our daily lives to be able to move that needle a little bit. Because once you realize that you're sitting with an expert, all of a sudden your questions might change. All of a sudden you're maybe not thinking about blaming the patient, but you're thinking about like, man, there were some other factors in your life that like brought you to this point that now we're going to work through this together. And all of a sudden that relationship is no longer a paternalistic one as we've been trained to kind of handle medicine, but it becomes one of reciprocity. And it becomes an equal one where the patient is going to guide some things and you're going to guide some things. And together you create a foundation of trust that the patient then doesn't really become lost to follow up. Because they're motivated to come back and see you again because they feel like they're a true partner in their care. They're vulnerable enough to share with you their concerns, their fears. They let you know about maybe the family history or the aunts that never shared that they were diagnosed with a cancer. And all of a sudden you find, oh, maybe there's a genetic situation going on in this family, right? And so I do think that concept of understanding the culture of medicine and how there is inadvertently a power differential when you walk into that room with the patient and trying to eliminate that as much as possible by recognizing the humanity of every patient and person that sits in front of you. That's at least where I start. It's like I start to think about the big picture questions. I get very overwhelmed very quickly. But in terms of what I can control every single day, and then when it comes to like the research questions, I think the idea of cultural humility and having patients be drivers of research questions and protocols is also really important as well.
I wanted to mention, well, I'm a retired public health nurse. I worked for 37 years as a nurse. And I noticed something that when I first started working, I had ideas about how to walk into a person's house and how to interact with them and how to provide it, information. But I also learned that my desires were not necessarily the patient's desires, and that you need to listen. You'll need to listen to their perception of what's going on. But the other part is, I learned that many people don't realize their own biases before they even walk into a room. And because of that, you may project a feeling, I don't care, you know, that this is not important. The reason I'm bringing it up is because I have a family history of high blood pressure. So I told my children they need to pay attention to that. And they said, every time I go to the doctor, they check it and it's fine. And I said, but you have a family history of high blood pressure. They need to pay more attention to that. So, to say the least, I realized that our education of the medical field does not include people of color, mentally, people of color. We are taught, how do I say it gently? In these places that we get our education, we are taught about the white race, the majority. You walk out of there with that information in your head, whether you're black, white, whatever, you are trained to know how to take care of that group of people, okay? And even though you may be black, when you walk through that door, you are spouting the same thing, okay? So it is also providing those clients with the feeling that even though you are black, you don't see me at all. So my concern is trying to get the system to change how it provides education to those who are going out there in the community. I really felt like I could work in any hospital that had lots and lots of white people when I finished school. But if you put me in a predominantly Black or predominantly Indian or Asian or whatever, I would not know how to deal with it, okay? So when we stop and think about it, let us go back to just the education. What does it mean to have, you know, Mongolian stains? I remember that really good. What does it mean? And why do you see it on some children and not? Do not let the mother think that somebody's beating her child because you mentioned, oh, why is that there? Okay. So I think we need to, when I think about priorities, isn't it the minority race that's not getting the thing that it needs? So why isn't that our priority?
Yeah.
Why is it so much in every field that they're falling behind or they dying? You know, working 27 years in public health, I got to a point where I said, so is it going to be this way for another 37 years? Where do we start to make the changes?
Yeah. Again, a deeply profound question and comments. Thank you for sharing. I think it's challenging when you think about the educational structures in the United States and medical education. And when I alluded to the culture of medicine, for so much of us, we're just, this is the truth. This is the way. This is what I've been taught. There is the culture of apprenticeship when you learn clinical medicine of I'm going to do things the way that my attendings did the things or my chief resident. And not, there's also a bias towards people in healthcare generally not questioning systems, right? The type of people who choose to have a career in healthcare they really want to help people, and they're really good students, and they're going to follow the rules, right? We're rule followers. We're sitting in this room because we followed certain rules in our society, and we haven't necessarily questioned them, right? So it's like the type of people that are in this profession, by and large, are very susceptible to kind of following the system that has been set up by structures that date back hundreds of years in this country, right? And so I think it's really important. And when I was a medical student, I advocated for like trying to understand healthcare policy and leadership. Like we need to be able to understand systems of power starting from when we're medical students. And we need to understand how cultural humility is so necessary and so critical in the day-to-day interactions of our lives. And that education has to start from at least medical students when it comes to medicine, so they know how to question things. They know how to question, like, why are we using a metal speculum if patients prefer plastic speculums? Aside from environmental risks, we'll get into that talk for another day. But like, why do we have to like do a why do we have to do the pap smear? Can't patients self-collect? Or why do we have to do the gonorrhea swabs? And can there be another way to do this that's more patient-centric? And that those questions are born not only of like listening to patients and what patients' priorities are, but also a recognition that it's really hard to change once you become like a whole doctor, of like, your way is not the best way. It's probably actually maybe a little bit of the wrong way, or at least you're maybe not giving it to patients in the way that they need to hear in the context of their lives. And that humility is something that's very, very, very hard to teach. Some people have it innately, but I think that teaching the humility component to medical students is critical. And maintaining that. So at least I found in my experience that like in medical school, we did all this kind of what I call the soft, fluffy sciences. We learned about health disparities. You got taught about the cultural humility. You got taught it to like kind of think about people in the context of their lives and place and health. But you went to residency, and man, I was just trying to check that cervix, get that patient delivered, and like make sure that I learned all the anatomy of the pelvis, and make sure that I could like run that list and know the urine outputs. And you just forget about the context of patients and where they're coming from, right? And so there's a lot of undoing of the knowledge that might have been laid if you're lucky enough to go to a medical student that encourages that cultural humility. A lot of the undoing of that happens at the graduate medical education level. And so thinking about how do we integrate kind of an equity-focused curriculum to our residents and to our trainees that are at this really hypercritical point where they're learning the medicine, but kind of forgetting about the public health and the social impact and all of that. And that's the final stage right before we give them the stamp of approval to go deliver care in America, right? And so that's also a really important part that we need to consider as well.
Yeah, I have just one question or comment. That was an outstanding.
Wow, that was just absolutely fabulous. And I think those last two comments were so important. So listening to the patient, in the days of EMR, that's harder. We used to only be able to get the history from the patient. We didn't have this huge computer database. Absolutely critical. And the point about our medical education system and our systems of care. Just thank you so much, Dr. Gamble. We have until 9:25 for a break. So talk amongst yourselves, talk to Dr. Gamble, talk to the Brief and Brilliant people, and come back at 9:25. All right, so grab your seats. I'm going to do a super quick introduction of the person who's going to do an introduction of our next speaker. So Dr. Beth Burnside, for people who do not know Dr. Burnside, she is a very distinguished faculty, actually in the Department of Radiology, but the context with which she's, the reason she's here is because she's the PI on the Birch training program. So you'll hear a little bit more about that. And for those of you who don't know about Birch, you're going to hear about it because it is one of those national programs well-funded to build research in women's health. So thank you so much for being here, and I'm going to turn it over to you.
Thank you so much. It is an honor to be here. There's a lot of energy in the room, as Dr. Hartenbach was trying to quiet people down. The conversations are the most important, right? So It is my distinct pleasure to introduce Dr. Janelle Sobecki. So I met her when she was really early in her assistant professor journey. She is an assistant professor in the Department of OBGYN, which you all know. And soon after that, she became a Birch Scholar. So Birch is building interdisciplinary research careers in women's health. It is a K-12 award and it's very competitive, but we do women's health and sex and gender differences research. And Dr. Sobecki was immediately recognized as one of the best and the brightest. Pretty much everyone in her ecosystem said that. So after I met her, I realized that not only is she a scholar in the research realm, which you'll hear about shortly, but also she is a fearless leader and teacher with her leadership of the Women's Integrative Sexual Health Program, the WISH program. And I don't know if you have ever heard her talk about the pride in which she presents that program. It's truly inspiring. She is also a remarkable mentor. So she has been the resident research co-advisor in the Department of Obstetrics and Gynecology, and that is a labor of love where you work with residents on their research projects. But finally, I want to share with you something special about the Birch, and if you ever want to know more, please just reach out to me. But the original PI of the Birch was Gloria Sarto. And I think the best thing that I can say about Dr. Sobecki is that she is absolutely the person that Gloria would have wanted to collaborate with, mentor, and would be so proud of. So it's my pleasure to introduce you to Dr. Janelle Sobecki.
We're going to check the mic. It's working. Great. Well, thank you for that just tremendous introduction. I'm so proud and happy to be here to share a little bit of my Birch work with you all today. So we are going to shift gears to a really important topic to me and many who take care of patients with cancer, which is survivorship issues. And the issue we're going to really focus on today is the issue of osteosarcopenia in those with gynecologic cancers. I do not have any important disclosures. So what is osteoporosis? We have a general understanding, certainly as caregivers of obstetrics and gynecology, but in general, osteoporosis is low bone mineral density, which is a loss of bone mass. It's also a decline in the quality of the bone, and this leads to an increased risk of fracture, right? So osteoporosis in and of itself is a risk factor for what can cause a significant morbidity and mortality event like a hip fracture, leg fracture, et cetera. And what's important about this disease is it's silent, right? There's absolutely no symptoms until the fracture happens, right? And so that can make it really difficult to catch people at risk when there's no symptoms. And then if you're not doing routine screening, people can have a really life-altering and quality of life-altering event. What's also important to talk about in the context of this talk is osteosarcopenia. So this is kind of a newer definition, and sarcopenia itself is the loss of muscle mass and strength and function. And osteosarcopenia is the presence of osteopenia or porosis and osteosarcopenia. And what this does is we know from newer data that the combination of low bone mass and low muscle mass is even more risky for people, greater risk of falling, right? And if you are weak and your muscle mass is low and your bones have low density, if you fall, you're going to be at a higher risk of fracture, right? And so this combination is, we're going to talk about, is incredibly important for patients undergoing cancer-directed therapy, but is a kind of a newer entity that we're really starting to focus on because the sum of the parts is worse than either of these individual issues. This is a very simplistic graph, but important in the context of what we're going to talk about today. So this is basic healthy
bone physiology, okay? So this is just your healthy average people without any comorbidities. And what you guys can see here that's really important is that, you know, everybody's bone mass, male and female sex, are going to peak around age 30. So pretty much by the time you're age 30, you have the maximum amount of bone density that you're ever going to have. And then slowly for males over time, this is going to decrease. What we see in women is that after menopause, you guys can see here this notch, right? So at the time of menopause, estrogen goes down. Estrogen is typically bone protective. And so during perimenopause and menopause, bone density takes a pretty steep decline and it kind of levels out a little bit. But wherever you are, if you've got a sharp decline, you're never going to get it back, right? And so this concept is going to be really important as we get to some of the core data and graphs that I'm going to show you guys in just a bit. So let's talk about some of the stats because that's important. So because of menopause and the graph I just showed you, osteopenia, osteoporosis is predominantly female disease. We know that this affects female sex individuals more than males. About 8 million women over the age of 50 have osteoporosis. About 27 million women, in addition to that, have low bone mass. So that's kind of your osteopenia group. 71% of all osteoporotic fractures are in female sex individuals. In the United States, 1 in 2 women over the age of 50 will experience a fracture in their lifetime. And some Wisconsin-specific data, 1 of every 20 women in Wisconsin who are enrolled in Medicare will experience a fracture every year, okay? That's a lot of people. It's a lot of people in our state. It's a lot of the people that we take care of every day. So what are some of the general risk factors for osteoporosis? So age, right? You guys saw that graph. Tobacco use, low BMI, heavier alcohol use. This is typically estimated in osteoporosis studies as more than 3 drinks per day. If your parent has history of a hip or spine fracture, you are at higher risk regardless of any other factors. Secondary osteoporosis, so this can be secondary to other medical health conditions, so things like diabetes, anorexia, even HIV. Premature menopause, that makes a lot of sense to the people in this room, vitamin D deficiency, and even medications can cause bone density issues, right? So things like aromatase inhibitors, chemo, which we're gonna talk about a lot in a few minutes, glucocorticoid use, you know, your GnRH agonists. There are a lot of very common comorbid conditions and treatments that can play a negative role in somebody's bone density. Rheumatoid arthritis, also a really common condition associated with this. So how does cancer play a role in this? This is a talk about this, so you can imagine cancer makes it worse, right? So there's a higher prevalence of bone loss in patients with cancer just across the board. This comes from a variety of factors. So there can be direct effects of cancer on bone cells, right? So if a patient has bone metastases, those metastases are changing the architecture of the bone and can make bone weaker and more prone to fracture. There are also a lot of secondary effects from cancer-directed therapies. So we know that radiation, particularly in our oncology group, has about associated with about at least a 10% risk of pelvic insufficiency fracture. So radiation is bone toxic. Chemotherapy itself is bone toxic, and that's something that is an evolving understanding. People with cancer have weight loss and muscle mass loss and reduced activity, right? So leading to that sarcopenia piece, also a lot of nutritional deficiencies secondary to malignancy, in addition to all those other comorbidities that I just mentioned. So gynecologic cancer in particular, so we remove ovaries in nearly everybody with some caveats. Many of our patients receive these bone toxic adjuvant therapies. Many patients that we take care of go through treatment prior to that natural age of menopause, right? So leading to premature ovarian insufficiency. Many of our patients have long-term survival. You know, this issue is more pertinent for the patients that are going to have long-term survival, right, than our patients who are not, but many of our patients do. There's also incredibly little data in this area in gynecologic cancer and bone loss, and we have absolutely no standardized recommendations for how to take care of people and screen them. So screening in general, many are familiar with DEXA. That's kind of our gold standard measurement of bone mineral density, as well as FRAX tools. So basically, your bone mineral density data from your DEXA goes into FRAX, and FRAX takes into account all these other comorbidities and gives you kind of a 10-year estimate of risk. And we use that data to determine who needs to receive medications for bone loss. Dr. Hartenbach and Dr. Rice and I wrote a review article on this topic and very humbly found that there has been basically no good research done in gynecologic cancer and bone loss. But the NCCN Bone Health Guidelines, national guidelines, have over 300 references. Not one of them is in gynecologic cancer. Most are breast and prostate. And holy cow, are our patients at risk, right? That seemed crazy to me and kind of led to this journey. Here is a summary of all of the various guidelines from ACOG, the National Osteoporosis Foundation, NCCN, ASCO. None of them agree. None of them tell us exactly what we should do with these patients. So lots of variability, and none are gynecologic cancer specific. In this review article we wrote, we tried to summarize the very little data that was out there to come up with some recommendations specific to gynecologic cancer patients. And what we had summarized was that screening is probably going to be necessary every 1 to 2 years for patients with high risk gyn cancers, which we, based on data, defined as a premenopausal patient undergoing BSO and or adjuvant therapy, women undergoing pelvic radiotherapy regardless of their age, and then women with those other comorbid increased risk factors for fracture. This work led to a nifty, I say nifty because it's kind of cool, retrospective study that we did. And what we did was we measured bone mineral density from CT scans that patients already had performed. And we went back and over a period of 5 years measured the bone mineral density directly from their CT scans. This is a methodology that was actually pioneered by Perry Pickard, who's a radiologist here. He's the pioneer of this technique. And what a really awesome thing for patients that are undergoing CT scans all the time in their course of their therapy. Their bone density is just sitting right there to be measured, which can be a really nice screening tool and one, you know, we're working on trying to prove is accurate. So you guys can see here, so basically you can measure what's called Hounsfield units on the L1 spine bone on any CT that a patient has had performed. And we did this retrospective cohort, and what we found was that basically between baseline, 1 year, 3 years, and 5 years, at every single time point, patients had a significant reduction in their Hounsfield units. For reference, Hounsfield units in an average healthy patient should go down 2 Hounsfield units a year. So in 1 year, we're seeing decreases of 30, 40 Hounsfield units. Patients with baseline normal bone density by 1 year, half of them were osteopenic or osteoporotic in this retrospective sample. Chemo and smoking, and if their bones were had low density before they started cancer treatment, were independent risk factors for bone loss. I think we're going to get to this. Okay, so all of this work and all of this data led to my core Birch project, which is a prospective evaluation of bone loss and osteosarcopenia in women with gyn cancers. We have been accruing for about 1.5 years. We've accrued over 100 out of our planned 150 cohort. Accrual has been tremendous, thanks to my wonderful partners and a lot of good teamwork. We are measuring bone mineral density at baseline, 6 months, 12 months, and 24 4 months. In addition to DEXA, we're doing a lot of cool exploratory stuff to try to figure out if there's a better and easier way to screen our cancer patients for risk of bone loss, particularly because we think the bone loss in these patients is more rapid, and DEXA may not be the best way to kind of pick up the cellular metabolism of what's happening in the bones. So in addition to that gold standard DEXA, we are going to go back and do that same opportunistic CT and compare it to DEXA and see if those CT scans are just as good for kind of picking up and screening these patients. We're doing some really cool bone architecture studies and exploratory things with something called 3D Shaper and trabecular bone score. What that does is it picks up the microarchitecture of the bone, which may be more predictive of risk of fracture than the density itself. We're collecting serum bone turnover markers, so resorption markers, formation markers. We're doing some good sarcopenia measures, so patients are doing chair rise, validated chair rise, hand grip strength. We're also measuring their muscle mass with kind of cool tool called BIS. And then we're also, nutrition is incredibly important in this interplay. So we're collecting albumin on these patients and doing patient-reported outcomes with a validated nutrition and weight screener called the SGA. This is our schema. So we are subgrouping our patients by menopause status and by the type of adjuvant treatment that they receive to try to figure out which of these groups is at most risk. We have certainly some hypotheses in this. You guys get to see the very first data from this first 100-ish patients. So preparing for this talk, we've so far got 95 patients that I can tell you some data. Average age 56. This is about a decade sooner than normal osteoporosis screening that happens at 65, right? So this is a younger at-risk cohort. Race ethnicity looks like a typical, Wisconsin-based cohort. Cancer type, predominantly uterine and ovary. That's, typical with what we see in clinic. We've got a handful of cervix, vulva, vaginal, and pretty good distribution on stage. The earliest and easiest to recruit were stage 1 patients who were just undergoing oophorectomy, because that's what we see most are endometrial cancer patients. But so far, nice demographics as predicted. And here is just descriptive data. So this has not had any statistical analysis. This is simply we have 1-year data now on 42 patients. What I really want to point out to you guys are these premenopausal groups, right? So this is their mean total spine T-score. The actual bone density pretty much mirrors this. And what you guys can see is these premenopausal groups are having a very large decline in their T-score, right? So this oophorectomy only group's going from 0.9 to 0.2. Our pre-meno oophorectomy and chemo group is going from -0.1 to -0.9, right? -2.5 is the diagnostic cutoff for osteoporosis. I like pictures and graphs, so this kind of summarizes it. So far, it doesn't seem like our postmenopausal group is changing too much, but you guys can see these premenopausal groups are taking a pretty steep decline, even by 6 months. The oophorectomy only group is kind of stabilizing, so that sort of mirrors that graph that I showed you about natural menopause, which is sort of interesting. But this chemo group is having a pretty steep decline, even following oophorectomy and chemo. So obviously much more sophisticated analysis to come once we've got our powered cohort. But the early data is mirroring our hypotheses that these women are going to be at higher risk, and we likely need to figure out how to intervene on this before it happens. That's it. I have many, many, many people on this bone loss team to thank. Amy Gray, who is the most fantastic research coordinator. I am so lucky to have her. My partners, especially Laura Huffman and Ryan Spencer, who have been really, really motivated in recruiting their patients. The Birch, all of my many mentors, and Neil Binkley is an osteoporosis expert here at UW and has partnered with me and my team at the Osteoporosis Clinical Research Program, and they are hugely instrumental to this work. So thank you to everybody.
That was an amazing talk and super interesting. I know I have a question myself, but I'm gonna watch the chat here and start if there's anyone in the audience who wants to go first. We have about 4-ish minutes. So I know it's a short question time. Okay, I want to pipe up since.
Yeah, yeah.
My question is, considering the race and ethnicity inclusion and thinking about how we can try to bolster our inclusion in research, do you and your team have any strategies in mind for trying to increase that inclusivity? I'm curious whether those numbers really mirror the rate of the folks that you guys are seeing in gyn-onc, because the rates are lower than what we see, like, for example, in our general OBGYN clinics. And then if you have ideas of like how to maybe, is it appropriate to bump up those rates somehow?
Yeah, absolutely. That is a well-timed question. I actually have been meeting with our community partners group and trying to figure out, Julia's nodding her head. We've had recent conversations about that, so very timely talk. The demographics so far for our study are mirroring what we see typically in our cancer centers clinical trials. And this is even a larger, area of improvement, even for our broader, Carbone Cancer Center clinical trials group. We are potentially looking at trying to expand the study for patients that are able, potentially even into like the Milwaukee area and things like that. There are a lot of IRB red tapes that get in the way of doing that, but we are working on it, and we're working with our awesome community partners group who have such a tremendous wealth of information, and I think that's actually going to be a really good partnership that's in the making. Yeah, great question.
Hi, good
Hi,
job.
Matt.
Your last slide, I have two questions. One,
Yeah.
it looks like in the postmenopausal oophorectomy groups that their bone density is relatively stable. So do you think from that data you could extrapolate safety of oophorectomy after menopause? And two, the postmenopausal oophorectomy chemo group is lower. And do you think that has something to do with the biology of those patients presumably having cancer relative to the other patients? Or do you think it's something to do with the therapy?
That is a really good question. The premenopausal oophorectomy chemo is currently our lowest accrued group. So the power in this number is not as good as our premeno oophorectomy only group. So it's really, I think it's really hard to conclude anything from kind of that starting point. But maybe, right? There are some molecular questions that we have about whether the presence of metastatic cancer is causing different bone, pro-resorptive issues in the body. That may be a lovely translational study to come. We think maybe, that there's something going on in the body in addition to everything we know already, that maybe these patients, by the time they get to presumably an advanced stage diagnosis, have already had some reduction that we don't know about. There's definitely some good theories out there that this might be why we're seeing this group starting a little bit lower, and starting lower is no good, right? We know that's actually an independent risk factor for, being worse kind of after cancer treatment. Yeah.
Great. And sadly, I have to kind of move on from here. Thanks for an amazing talk. That was great. Okay, and then I'm hoping to welcome Dr. Tiffany Green to give our next introduction.
Good morning. Am I the only one who's awake? I'm not awake, but hopefully y'all are. All right. I am so pleased to be able to introduce our next two panelists. I'm going to start with Sherry Branham. Sherry has her bachelor's degree in social work. She is also a doula. This is a long list. Okay. Certified peer support specialist, a family recovery coach, and has been a justice reform advocate for many years. After giving birth while incarcerated in 2014 due to a crimeless revocation and lack of treatment options, Sherry dedicated her life to improving conditions for incarcerated pregnant people. and expanding services to allow family reunification. And just to interject here, which I usually don't in bios, as someone who serves on maternal mortality review, thank you for this very, very important work. It is vital in helping to move the needle. She believes that no one should have to go through birth while incarcerated alone. Sherry has experience working with many different communities, giving her a unique set of skills that allows her to provide one-on-one support and project monitoring and development at a larger capacity. Sherry shares her story with the hopes of bringing awareness to how pregnant incarcerated people are treated and the need for change in our carceral system. She has also devoted her time to seeing Wisconsin have a successful prison doula project, following the work of the prison doula projects across the United States. In doing so, she hosted a pilot of the Pregnancy and Beyond curriculum in Brown County Jail, where the evaluation process is already showing positive outcomes. And so she connected with Dr. Denson on this work. And that's a good segue into Dr. Denson and her work. She is a research assistant professor at the UW School of Medicine and Public Health. She serves as a director of the UW PRC. Can we give her some love for that? Okay. She does a lot of stuff. I couldn't do that, sis. Okay. Engaging researchers, community members, translational partners in expanding community-based prevention research and health promotion to improve the health of women, infants, and families here in Wisconsin. She is passionate about maternal and child health, sexual and reproductive health, and health equity, with a focus on understanding how social and structural drivers affect health outcomes. Her research interests are rooted in collaborating with community partners like Sherry to address health disparities through community-engaged research. She's particularly interested in building robust community partnerships and centering the voices of those who are marginalized through capacity building and innovative research strategies. And we are going to hear about this today. Dr. Denson and Sherry, please welcome. Thank you.
Okay, so thank you everyone just for being here, and I'm really excited. And thank you, Dr. Denson, for inviting me, of course. So in 2014, well, a little backtracking, I grew up in very dysfunctional household and was addicted to opiates and arrested at the age of 18. And in 2014, I was using, but found out I was pregnant. So went to my doctor to get put on medical assisted treatment, thinking I was doing the right thing. And long story short, there was no options for me. So I had my probation officer send me to jail to wait for a treatment, and that treatment never opened up because there was a lack in our state, across this whole state. So I went through those traumas that I can never explain in words how painful it is. You don't get a picture, you can't pump and ship out your milk. Like, I encountered all of these barriers. And when I finally did get home to my daughter, I saw these are needs and we need to fill those needs. And there is a lot, unfortunately. Do you want to add on that?
What struck me by Sherry's story is, like so many other birthing people, she did everything right. She went to her doctor. She wanted to have good health for herself and for her baby. Her doctor did the right thing, put her on medicated assisted treatment. And then out of their control, out of the doctor's control and out of the patient's control, a probation officer decided, you did not run this by me. I did not approve this. And so that is why Sherry ended up going to a maximum security prison. There are 3 women prisons in Wisconsin, and pregnant women go to the maximum security prison. Again, she did everything the way she was supposed to do. And that is what struck me.
And that's a picture of me with my daughter, who is now 9, while at Tachita.
So Sherry and I have been working with 4 programs together and grants. And we're not going to go into detail on them because we don't have enough time, but we want to provide some context for you. So one of our research projects that are currently going on, we're still recruiting for, is Where Do the Babies Go? And Sherry and I were at a retreat fall of 2023. The years go so fast. And we had it was a 3-day retreat, a lot of conversation. And somebody said, well, where do the babies go? Because some states have prison nurseries. In Wisconsin, we don't have that. So when a birthing person gives birth, they will, so if they're in their county jail or if they're in Tortita, they're going to go in the local hospital, and that's where they're going to give birth, usually accompanied by 3 correctional staff. And so they'll be there at the hospital 24 to 48 hours. Then they go back to their jail or prison, and then the baby has to go somewhere. And so that's what the discussion came. Where do the babies go? Infants of incarcerated mothers and their caregivers. So we started doing semi-structured interviews with birthing people with that lived experience and caregivers who took care of newborns because the mom was incarcerated. And we are doing semi-structured interviews with the moms and the caregivers. We also did a co-design doula project using group concept mapping. And we had groups in Madison, in Milwaukee, and virtual, so we could get some geographical representation. And we are in the middle of analyzing that data. We know we'll have to do 1 or 2 focus groups to work with our community, to make meaning with our community of that data. We got a grant to support the Babies Project so that Sherry and 1 other person with lived experience can actually do all the maternal interviews for the Babies Project. And then Sherry will talk about the prison doula program.
Yes, and actually, in Jill's bio, it is so spot on with the work that she's doing. She really engages people with lived experience, and, it just makes the work so incredible. Even like the group concept mapping, like people appreciate that, or the interviews, they feel supported. It's just really awesome. So what we're working on is the Wisconsin Prison Birth Project, and it is following all of the birth projects across the United States. So Alabama, if you haven't seen Tutwiler, it's a video. Actually, Alabama was one of the worst prisons, and then they started a doula project. Minnesota is another one that is right next to us, and they have these resources that fill those gaps, right? The doulas accompany the people to the birth. They take the picture, so you don't not have one. Like, I don't have one of me and my daughter during the birth. They support lactation services. They do pregnancy and beyond curriculum, which is a prenatal group. And they also do separation visits. So after learning about all of that, I got a bunch of stakeholders involved, including Dr. Jill, and we just had conversations about how to build this, right? And there's some barriers, but our anticipated start date is January 2025. So I'll be a program coordinator. Feel free to ask any questions, but it is an exciting time. So.
Oh, Sherry, can you move it for me? Okay, so with community engaged research, it's really about relationship and trust building. Many in the community, don't trust academics or research for good reason. We have a poor track record. And so doing community engaged research takes a lot of time and a lot of effort, because the main thing you want to do is build trust, build relationship, and that is a continuum. It's not a start and finish, that is continuum. I want to acknowledge Jillian Jacqueline. She was a partner with Sherry before I met Sherry, and she was actually responsible for Sherry and I having a relationship together. So we forgot to tell you how we met. So as you can probably tell, Sherry's very, very tenacious. And she is from Green Bay, and so she was working with some Green Bay faculty there. And so they actually reached out to the Wisconsin maternal mortality team, saying like, what outcomes have there been for mothers concerning morbidity or mortality, mothers who were incarcerated? And they didn't have any information for her at that time, but they connected her to me. And Jillian did such a good job of modeling how you should work with community. So much so I was like, look, lady, back off, I get it. But I'm so glad that she did it. She was really upfront. We were together for like months. We did, meetings together until she felt safe enough, like, oh, I think Sherry's in good hands, and she's not going to be exploited. And so she was the one who was like, hey, I want Sherry to be involved. If you're in research questions, and if you're doing grant writing, grant proposals, if you're doing presentations, if you're going to do a publication. And so that was really modeling for me as a new researcher. And I know to do that if I'm ever doing a warm handoff to someone. That is really important. And that's a big part of that trust building when you're working with community. And Sherry's going to talk about her roles in all these, which is a lot.
Yes. So Jill has asked me to be on the community advisory board for the Where Does the Babies Go? I also do the interviews, as she's mentioned. We did the group concept mapping, and we actually identified some barriers. So people are all over the state, right? Like, this doesn't affect one community, it affects everywhere. So initially we did one in Milwaukee and one in Madison as target areas, but then Jill and I discussing, hey, what about, there's people we're missing, right? So Jill got us to do a virtual one, which went really, really well. But she's really just comes to me, and I don't have a master's degree. Like I stand here as somebody who just cares deeply about this, and I share my story to get people to know, like, hey, this is an important issue, and we should be doing something about it. But Jill, she just welcomes me into that space and makes me feel empowered, and I really appreciate it. I think that's one thing just across the state with research and things like that. There's people who have been incarcerated or, in these experiences, these traumatic experiences that schools want to study or just learn more about. And getting them involved is critical because it's going to give you a different perspective. And it's going to help with identifying those barriers, whether it be what you're studying or during the study, right? Like, things come up and where does the babies go? And Jill will come to me and the person with lived experience, and we can just process that. Like, is this the best way to do this? Or what does this look like? She's very great at it.
So for the Babies Project, we had, as Sherry said, we had a project community advisory board. We had a technical advisory board made up of professionals from social service organizations that serve women with these kind of experiences in Madison and in Milwaukee. We also had community, when we did our group concept mapping, who really helped us focus, including Sherry, on what the focus prompts would be or research questions. And Sherry was very instrumental in recruitment, because there are some spaces that I will never know about or be welcomed in. This is a community, Sherry's a brave person. A lot of people go through this experience, never talk about it. Their neighbors don't know, their employers don't know, sometimes their children don't know, because there's a lot of shame and stigma and judgment that is associated with it. But there are some groups there that are closed groups that I have access to and should not have access to, that Sherry can get into those groups. And what Sherry does also is, when she's talking to a group about me or the research that we're doing together, she's putting her reputation on the line. So she's saying to people, this is a safe space. This is not a research project or researcher who's going to harm you. So again, that's a bit greater responsibility for me to make sure that I don't jeopardize any relationships that Sherry has already developed.
Yeah.
So community engaged work is not linear. It can be messy. The more people you have involved, more geographical locations, you have different, races, ethnicity, age groups, all of that brings in, is not straightforward. It can be very messy, but to me, it's also the more exciting part of it. And so there's challenges. Some of the challenges that Sherry and I have supported each other and had a strong relationship with each other, but we also have sort of had separate paths, which made sense, right? Because I'm doing things one way in terms of the research or the Prevention Research Center, and Sherry is doing things in terms of service delivery. But we've always maintained a close relationship. So we want to talk about some of our different paths.
Yep. So when I initially started reaching out to facilities, I reached out to Brown County Jail because I'm in Green Bay. And I just wanted to build that relationship, right? Like that's huge. So I would meet with administration. I actually got connected through the sheriff to the jail admin, and me wanting to see research and service delivery, and like Jill's amazing. So we had a meeting together, and the ultimate reaction we got was kind of like, don't bring up research, because corrections is just different. And in my mind, I'm like, let's gain this information, but that makes it challenging when that's the population you're trying to get this information on just to help, right? So I kind of just diverted to where we're going to do the services, and this is what we're going to do, right? And I did a group, went very well. Obviously there's other areas you can research even without, say, going into a correctional facility. But just having that relationship, I think it's really powerful for the work, because you're also, just like Jill said, making sure people are like supported, not being monopolized. I've had that in my life where, and it doesn't feel good, but doing this work with Jill does feel good. So I know that was one challenge.
I also think that when we're talking the doula project, that was Sherry's lived experience, and it made sense to her. She wanted to do that right away. She wanted to do that, and she wanted to do that because
I wanted to do it because there's an issue, and we, as a state, need to solve it, and we can't alone, So with the research and community services, I feel like Jill's very knowledgeable of this. So the ultimate goal is just kind of what I said, to complement each other. So I'm doing this service delivery, but I don't have that experience with the research, right? And I guess initially when I decided I want to find these answers, because there was no research on it, right? The DOC actually doesn't have to do research. They don't have to track pregnancies or any information on pregnant people who are incarcerated. So that's kind of going back to another barrier, right? But we definitely make it so that the work just complements each other, where we can get the services, serve the people, and also get the answers that we need. And that looks like that was the last slide.
Stay, Sherry. Stay. That was just magnificent. We have to clap again. Like, incredible. That's incredible work. You know, it's so brave to share your story. And I think almost everybody in this room has a family or a friend who has an addiction issue. So sharing your story is just so powerful, just so powerful. So the work that you and you, Sherry, and Jill are doing is just so impressive. Do people have some questions? We have a little bit of time. I don't want to put Jill under any strain, so you just sit and recover. I'm sure Sherry would be willing to field a question or two. Would that be okay,
Oh,
Sherry?
yes, absolutely.
Hi, thank you so much for talking about this. There were 3 out of 4 programs I hadn't heard of, so I'm really interested in looking more into those. I had a question when you said they didn't want you to talk about research when you first went into the facility to get connected with Brown County. Was it the jail administration, or they thought that the incarcerated people wouldn't want to hear about being research subjects?
I think sort of the second, right? Like there's not a lot of research on correctional facilities, incarcerated people. So we got to ask the question, why? You know? I think it is partially protecting people, but I also think it's just people not thinking, hey, this is an issue, you know? I think it's more overlooked, right? Because you don't think of somebody giving birth while incarcerated and what's that like and what are the barriers. And it's not even that the facilities like don't want the services. They do. They want that, but there's just something with an example, Governor Evers put funding for prison doulas in the budget, but it got taken out, you know? So just like looking at that, I think that is really key. Did that answer your question? I think so. Okay.
Other questions or thoughts? I'll just look at the chat. There's a
I have a question.
story. We have
Mhm.
somebody online wants to ask a question.
Yeah, when she said who took the money out of the budget?
I have no clue, to be honest, but policy is not my expertise. That is another thing.
Does anyone in
Okay,
the audience?
the reason I say that is that this is why it's important this month and until the vote to go out and vote and to vote in your best interest. A lot of people don't vote in their best interest, and that is how we change some things because that's how legislators usually determine the budget. And if we put legislators that don't care about our issues in office, we're not going to get the things that we want. We have to stop putting legislators in office that aren't working for the people.
Yes, agreed. Vote early and often. Other questions for Sherry? Okay, wow. I just want to congratulate both of you. I also want to comment that the UW Prevention Research Center is one of the CDC funded centers. And Jill's just done an amazing job with the PRC. But it's one of the PRCs nationally, and I think, if I'm not wrong, the only one that is using the CDC funding for maternal and child health programs. So we're really proud to have that. And we appreciate, again, you sharing your story, and Jill for all your work. Dr. Denson, just a friend of the department. Several people in the department have been involved in PRC projects. So thank you so much for being here this morning. And I'm going to let Dr. Sempenny close us out, but I'll just say fabulous symposium.
Thank you so much for having joined us this morning. We kind of did our little recognition for Brief and Brilliant a little bit earlier, so just a little bit of out of order. I just want to say, I know this was personally inspiring for me. I learned a lot this morning, and also just a plug to wherever you're kind of sitting in your seat this morning. There's probably been some pearls for you individually, and I think that even those such as maybe myself who identify mainly as a clinician, you don't have to be the researcher or the PI on these things to make an impact. So when we kind of open our eyes and look at our patients and understand them, we can see even just small ways to make improvements to reduce disparities. We have multiple learners right now working on projects to reduce disparities, both research and quality improvement. So I'm really proud of the folks in our department, our learners all the way on up. I hope that you enjoyed this morning as much as I did. Thank you for coming and have a great day.